Up to 90% of women suffer from vaginal atrophy 20 years after menopause. I
Yeah.
mean, 90%.
Yeah, it's honestly a staggering statistic.
It really is, especially for a condition that fundamentally alters your daily comfort, your intimacy, and, just basic tissue health.
Right.
And yet it flies almost completely under the radar.
Right. It's a profound medical blind spot, really. For decades, the symptoms of reproductive aging have just been, well, broadly dismissed.
Yeah, exactly.
We treat the hot flashes and, maybe we talk about bone density. But the structural degradation of mucosal tissue is often treated as just this inevitable, unavoidable consequence of getting older.
And if you are one of the millions of people staring down that diagnosis right now, you already know how incredibly frustrating the current treatment landscape can be.
Absolutely.
So that's why we are doing a deep dive today. We want to challenge that exact assumption. We have a very specific mission guiding us through our stack of research today.
Yeah.
We're asking, can exosome therapy actually reverse structural mucosal thinning and friability in patients who have totally failed local estrogen and PRP therapies?
And it's a great question because we are looking at a really fascinating array of sources to answer it.
Right, we're pulling from preprint laboratory studies on bovine colostrum, animal trials using these advanced hydrogel delivery systems, and the current FDA regulatory framework that actually dictates how these treatments might make it to a clinic near you.
It requires looking at a broad spectrum of data, because we are really talking about a true paradigm shift in regenerative medicine here. But
Yeah.
to understand why these newer therapies are so highly anticipated, we have to establish what is physically happening at a cellular level when that atrophy sets in. We really have to look at the architectural collapse of the tissue.
Okay, let's start right there then. The biology of mucosal thinning.
Yeah.
I mean, the root cause is obviously the drop in estrogen, but what is that drop actually doing to the tissue architecture?
Well, the vaginal epithelium, which is the tissue lining the canal, is incredibly dense with estrogen receptors.
Okay.
Estrogen isn't just some hormone floating around. It acts as a constant daily command signal that tells that specific tissue to remain thick, elastic, and well lubricated.
Right.
So when those levels drop permanently, whether that's through natural menopause, surgical removal of the ovaries, or chemical suppression, those receptors just go quiet.
The command signal just entirely shuts off.
Completely. And the physiological cascade that follows is, it's severe. Without estrogen activating those receptors, your local vascularization rapidly decreases.
Meaning the blood vessels.
Exactly. The capillary networks literally shrink. So the tissue is suddenly starved of blood flow and oxygen. And at the exact same time, glycogen production plummets.
Wait, so glycogen being the fuel for the local microbiome, right?
Precisely. Yeah. Without glycogen, the healthy bacteria die off, your pH level spikes, and you lose your primary defense against infection. But the most structurally devastating change happens in the connective tissue. The fibroblasts, the cells that are actually responsible for building collagen and elastin, they essentially just go to sleep. The architectural scaffolding of the tissue degrades.
Which leads to structural mucosal thinning and what the medical literature calls friability.
Right.
And for anyone who hasn't heard that term, it basically means tissue that tears or bleeds under even the slightest friction. It loses its normal ruggedness and elasticity. It becomes as fragile as like wet tissue paper.
Yeah, and you can easily imagine the severe dryness and the pain that causes. I mean, it dramatically impacts a patient's quality of life.
For sure.
The tissue is just in this chronic state of deterioration and vulnerability to microtrauma.
Which naturally brings us to the first line of defense, right? Local estrogen therapy. You apply a cream or a suppository directly to the area, and for a lot of patients, it works beautifully.
Yes, it replenishes the localized levels.
But if you read the literature we are looking at today, there is a distinct limitation to that approach.
Well, local estrogen is a maintenance strategy. It's not a structural cure.
Right.
It's an exogenous supply. So it temporarily bathes the receptors in the hormone and the tissue responds well. But the underlying cellular machinery, it hasn't been fixed at all.
Ah, I see.
The moment a patient stops applying the estrogen, the signal vanishes again and the atrophy immediately resumes.
And for a significant population, that maintenance strategy isn't even an option to begin with, right? I mean, the sources we're looking at specifically highlight breast cancer survivors.
Yeah, this is where the standard toolkit just utterly fails. Many modern breast cancer treatments, like aromatase inhibitors, they are designed to systematically eradicate every trace of estrogen in the body to starve the cancer cells.
Wow.
Giving these patients local estrogen is often strictly contraindicated. So these survivors are thrust into a sudden, chemically induced menopause.
Which must be incredibly jarring.
It is. Their atrophy is immediate and severe, and their doctors can't offer them the one hormone that would actually alleviate the symptoms.
So medicine had to look for non-hormonal alternatives to rebuild the tissue. And I know a lot of patients in this situation turn to PRP, right? Platelet-rich plasma.
Right, yeah.
This is the treatment where they draw your own blood, spin it in a centrifuge to separate the platelets, and inject those platelets back into the thin tissue. It's used heavily in orthopedics for joint repair, I believe.
It is, yeah. And the logic makes sense on the surface. Platelets contain a payload of growth factors that stimulate wound healing.
Yeah.
So the goal is to use the patient's own biological resources to trigger collagen production entirely without using hormones.
But the clinical literature shows a major flaw when applying PRP specifically to postmenopausal vaginal atrophy.
Yeah, the primary flaw is that PRP is an autologous treatment, meaning it is derived entirely from the patient.
Right.
If you are drawing blood from a patient whose systemic cellular machinery is already aged, sluggish, or, compromised, the platelets you isolate are going to reflect that exact same diminished state.
Well, that makes sense.
Their regenerative potency is fundamentally capped by the biological edge of the patient.
I want to make sure I'm visualizing this correctly for the listener. Using PRP to treat age-related atrophy is essentially like trying to renovate a crumbling 100-year-old house, but you're only allowed to use the original faded blueprints and materials salvaged from the crumbling house itself.
That is the perfect way to understand the limitation, honestly. You are not introducing any new architectural plans. You are just recycling tired materials.
Right.
And there is a secondary, very specific biological problem with PRP in this context.
What's that?
When you spin down whole blood to extract platelets, you inevitably capture neutrophils along with them.
Wait, neutrophils are white blood cells, right?
Exactly. They are the most abundant type of white blood cell, and their primary job is to fight infection by triggering inflammation.
Boy.
They are inherently pro-inflammatory. So you're taking a highly concentrated dose of inflammatory cells and injecting them directly into mucosal tissue that is already highly irritated, fragile, and friable.
You're basically throwing a match onto dry kindling while trying to plant a garden.
In many cases, yeah. The inflammatory response can outpace the regenerative benefits, especially in older tissue that already struggles to modulate inflammation.
Which perfectly sets the stage for the core focus of our deep dive today. If the old blueprints are faded and the materials are inflammatory, we clearly need to import a completely new set of instructions from the outside.
Exactly.
We need, like, a targeted software update for the cells. And that brings us to exosomes. Okay, Let's unpack this. What are we dealing with here?
Well, this is where regenerative medicine is experiencing a massive leap forward. But we really need to define exactly what an exosome is, because the commercial marketing often conflates them with stem cells, which is biologically inaccurate.
Let's clear that up right now. An exosome is not a cell.
It is not a cell. It does not have a nucleus. It cannot divide. It cannot replicate. And it is not, alive in the traditional sense. Exosomes are nano-sized extracellular vesicles. They are essentially microscopic lipid bubbles secreted by actual cells, most notably mesenchymal stem cells.
So if they aren't alive and they can't replicate, what is their actual biological purpose?
They are the communication network of the body. Think of them as highly specialized data packets.
Data packets, okay.
Right. A parent cell packs these lipid bubbles full of very specific molecular cargo messenger RNA, signaling proteins, lipids, and cytokines. The cell then releases the exosome into the extracellular fluid to travel to a target destination and deliver that payload.
Wait, I just have to stop and push back on the mechanics of this for a second.
Sure.
If an exosome isn't, a living cell, and it doesn't contain the live cellular machinery needed to actually synthesize proteins or generate energy, how can it physically rebuild a vaginal wall that is severely thinned out? I mean, it doesn't possess the bricks and mortar to do the building.
Right, but it doesn't need to carry the bricks. It carries the foreman who yells at the dormant workers to get off their break and start laying the bricks.
Whoa, I love that.
The brilliance of exosome therapy is that it doesn't attempt to build the tissue itself. It merges with the patient's existing sluggish cells, the dormant fibroblasts, and drops off a payload of instructions that forces those cells to wake up.
Okay, but what kind of instructions are we talking about? How specific does this actually get?
Incredibly specific. For instance, the exosomes we are looking at in these studies carry high concentrations of VEGF, that's vascular endothelial growth factor.
Right.
When that exosome merges with a cell in the vaginal wall, the VEGF directly stimulates angiogenesis, which is the sprouting of brand new blood vessels.
Wow.
It forces the tissue to rebuild its own capillary network, solving the blood flow issue.
So they are actively forcing the body to restore the vascular supply lines.
Exactly. Furthermore, they carry molecular activators for the 1-catenin signaling pathway.
1-catenin.
Yeah, it's a crucial genetic switch inside your cells. When the exosome delivers this activator, it travels to the nucleus of the patient's dormant fibroblast and physically flips the switch. It commands the cell to aggressively synthesize fresh collagen and elastin.
Okay, so that answers the architectural problem.
Yeah.
But what about the ongoing degradation? Because earlier we established that the tissue isn't just failing to build, it is actively breaking down.
That is where the regulation of matrix metalloproteinases comes in.
That's a mouthful.
It is. Metalloproteinases are essentially the biological demolition crew. Their normal job is to clear away old tissue, but in an atrophic state, they operate unchecked. They degrade the scaffolding faster than it can be replaced.
Ah, okay.
So exosomes deliver specific microRNA that binds to the demolition crew and shuts them down.
So the exosome therapy basically fires the demolition crew and simultaneously hands the builders a massive bonus to work overtime.
Yes. It is a complete hijacking of the patient's cellular machinery for the purpose of intense, rapid regeneration. And, because the exosomes are derived from young, highly robust donor cells rather than the patient's own aged blood, you entirely bypass the limitations that plague PRP.
And that transition from the theoretical to the physical data
Mm-hmm.
is where the literature gets incredibly compelling. Here's where it gets really interesting.
Yeah.
We have a preprint laboratory study in our stack looking at a commercial product called Purisome's IRC100 plus mom. And the primary source material for these exosomes isn't human stem cells at all.
No, it's not.
It's bovine colostrum, cow's milk. Specifically, the very first milk produced after a calf is born. I read that and immediately wondered, how does cow milk heal human tissue? I mean, wouldn't an extract from a cow trigger a massive immune rejection?
It sounds totally counterintuitive, I know. But you have to look at the evolutionary biology of mammalian reproduction. Colostrum is universally designed by nature to kickstart life. A newborn mammal is thrust into a hostile environment with a naive immune system and an unformed gut lining. The mother's colostrum is densely packed with billions of exosomes specifically engineered to trigger rapid tissue growth, barrier formation, and immune modulation.
But crossing the species barrier, a human cell listening to a bovine command.
Yes, because the signaling molecules contained in colostrum, specifically things like basic fibroblast growth factor or BFGF and epidermal growth factor EGF, they are highly conserved across all mammalian evolution.
Oh, I see.
The molecular shape of a bovine epidermal growth factor is so nearly identical to a human one that the receptors on a human vaginal cell literally cannot tell the difference. The biological language is universal.
That is wild. Let's get into the actual in vitro data from this study, because the researchers didn't just theorize this, right? They tested it on human cells.
They did.
They took human vaginal epithelial cells and human fibroblasts, grew them in a flat plastic petri dish, and performed a scratch wound assay.
Right, and for listeners unfamiliar with the technique, a scratch wound assay is exactly what it sounds like. You let the cells grow into an unbroken layer across the dish. Then you take a sharp pipette tip and drag it straight down the middle, scraping away the cells and creating a physical canyon wound.
Okay.
Then you put the dish under a microscope and measure exactly how long it takes for the cells on either side to multiply, stretch out, and migrate across the empty space to close the gap.
And in this experiment, they applied a 2% concentration of the bovine colostrum exosomes to the wounded human cells. If you look at the control group, so the cells left untreated, after 24 hours, they had only migrated enough to close about 24 to 25% of the wound.
Right. They were sluggish.
But the cells treated with the 2% exosome solution exhibited a massive acceleration in behavior, right?
Massive. After that same 24-hour period, the human vaginal epithelial cells had migrated 77%, and the human fibroblasts had achieved an 82% closure rate.
Wait, 82%? Visually, that means under the microscope, the treated cells are rapidly dividing and aggressively stretching across that canyon more than 3 times faster than normal.
Yeah, it is a statistically undeniable surge in the cellular activity. The bovine exosomes successfully delivered the command to multiply and repair, and the human cells executed the order perfectly.
But here is where we have to introduce a dose of physical reality. Applying a highly concentrated liquid exosome serum to a flat layer of cells in a stationary plastic dish is, well, it's completely different from applying that same liquid into the human vaginal canal.
Oh, absolutely.
Gravity exists, natural bodily fluids exist. If a patient just inserts a liquid serum, basic physics dictates that it's going to leak out long before those nanovesicles have time to find a receptor and merge with a cell.
That is the central pharmacokinetic challenge of this entire field.
Right.
You can have the most potent signaling molecules in the world, but if the retention time is poor, the clinical outcome will be zero. The exosomes need sustained, prolonged contact with the mucosal wall to deliver their payload effectively.
Which brings us to a brilliant piece of engineering detailed in another study we're reviewing. This team of researchers didn't use bovine colostrum. They used exosomes derived from human umbilical cord stem cells.
Yes.
But to solve the gravity and leakage problem, they encapsulated those exosomes inside a hydrige scaffolding.
They used a specific model to test this, 2 over-ectomized rats.
Right.
By surgically removing the ovaries of a rat, you instantly plunge the animal into a state of severe estrogen deprivation. It is the gold standard preclinical model for simulating human postmenopausal vaginal atrophy.
Got it.
The vaginal lining of those rats becomes incredibly thin, fragile, and devoid of blood vessels.
And to treat them, the scientists mixed the umbilical cord exosomes into a hydrogel made of hyaluronic acid. For those listening, a hydrogel is essentially a microscopic 3-dimensional mesh. It holds a massive amount of water, and within that water, the exosomes are trapped in the molecular webbing.
Exactly. When you apply that gel to the vaginal wall, it adheres, and as the body's natural temperature and enzymes slowly break down that hydrogel mesh over days and mix, it creates a sustained, slow-release drip of exosomes directly into the tissue.
The numbers on the retention time are what really caught my eye. Without the gel, liquid exosomes washed out of the rat's vaginal tract in about 3 days. By encapsulating them in the hydrogel, the researchers extended the retention time to a full 14 days.
14 days of continuous, targeted signaling.
Wow.
And the biological markers they analyzed after that 2-week exposure prove how effective that retention is. They took tissue biopsies and stained them to look for a specific protein called Ki-67.
What does the spike in Ki-67 actually tell us about the tissue?
Well, Ki-67 is a protein that is strictly present when a cell is actively in the process of dividing and multiplying. It's a universal marker for cellular proliferation.
Okay.
The tissue samples from the hydrogel-treated rats showed massive dark staining for Ki-67, proving that the dormant mucosal cells had violently woken up and were actively building new layers of tissue.
And they also measured a marker called CD31, right?
Right. CD31 is a marker specifically found on the surface of endothelial cells, the cells that make up the wall's blood vessels.
Okay.
A high concentration of CD31 confirms that widespread angiogenesis was occurring. The exosomes had successfully commanded the tissue to sprout a dense new network of capillaries, completely reversing the vascular starvation caused by the missing estrogen.
So the end result was a physical reversal of the atrophy. The tissue in those rats became thick, vascular, and structurally sound again. The combination of the highly potent umbilical cord exosome instructions with the slow-release hydrogel delivery system was just a total success in an animal model.
It really is a remarkably elegant solution to the delivery problem, and it provides a clear roadmap for how this could be applied clinically.
But if we are translating this from rats and petri dishes to actual patients listening right now, so what does this all mean for you, the listener? We have to talk about where the clinical evidence actually stands today.
We do.
Because you search online, you will find clinics aggressively marketing exosome vaginal rejuvenation right now.
Yeah, and we have to firmly anchor our excitement in clinical pragmatism here. If we look closely at human trials for related mucosal tissues like the endometrium, the lining of the uterus, the data is highly encouraging.
Right.
In clinical models treating thin, scarred endometrium, exosome therapies are demonstrating a 60% to 79% reduction in fibrosis and an 80% to 95% restoration of normal tissue thickness.
Okay, so the mechanism clearly works in human reproductive tissue.
It does. However, when we isolate the data strictly to large-scale randomized human trials for postmenopausal vaginal atrophy, the literature is still largely bare.
which is frustrating.
It is. What we have right now are pilot studies and small case series. The early signals in those small cohorts are very positive. Patients are reporting significant improvements in elasticity, natural hydration, and a sharp reduction in dyspareunia, which is painful intercourse.
Right.
But we simply do not yet have the massive phase 3 clinical trials required to unequivocally prove long-term safety and efficacy.
And that gap between early promise and definitive proof brings us to the regulatory reality.
Oh.
The FDA views exosomes fundamentally differently than they view PRP, and that heavily dictates what your local doctor is actually allowed to do.
Oh, the regulatory divide is immense, and it all comes down to where the treatment originates and how heavily it is processed.
Right.
As we discussed earlier, PRP is autologous. It comes directly from your own arm. Furthermore, spinning it in a centrifuge is considered minimal manipulation. Because you are just moving your own unadulterated tissue from one spot to another, the FDA classifies PRP as a Section 361 product.
Which means a doctor has wide latitude to use it off-label in their clinic tomorrow without needing to jump through massive regulatory hoops.
Correct. Exosomes, however, exist in a completely different legal and biological category. First, they're almost entirely derived from allogeneic donor sources, meaning they come from someone else, like a donated human umbilical cord or even cross-species like the bovine colostrum.
Okay.
Second, isolating, purifying, and concentrating billions of nanovesicles requires intensive laboratory manufacturing.
So it is not just a simple centrifuge spin in the back office.
Not at all. It is a highly complex, multi-stage biotechnological process. Because of that extensive manipulation and the use of donor cells, the FDA classifies exosomes as Section 351 drugs. They are classified as biologics.
Meaning they are treated with the exact same regulatory scrutiny as a new vaccine or complex gene therapy.
Exactly. To legally market and sell a biologic for a specific medical condition, a company must submit a full biologics license application. And that requires years of rigorous multi-center clinical trials to prove that the manufacturing process is safe, standardized, and effective for that specific indication.
I think a good way to frame this for the listener is to compare it to agriculture. PRP is like taking a cutting from a healthy plant in your own backyard and replanting it on the other side of the house.
Right.
It might not grow perfectly, but the government isn't going to stop you from moving your own dirt around. Exosomes, on the other hand, are like importing a highly engineered, genetically modified seed from a sophisticated laboratory abroad.
That's a great analogy.
Right. The government is going to demand a mountain of evidence proving that this new seed is safe, stable, and won't grow into an invasive weed before they let you plant it in the general population.
That captures the regulatory burden perfectly. The biological potential of the engineered seed is vastly superior to the cutting from your yard, but the standard of proof required to commercialize it is astronomically higher.
Yeah.
Currently, there are no exosome products that have achieved FDA approval specifically for vaginal rejuvenation.
So the science is sprinting ahead, but the massive clinical trials and the regulatory approvals are still, lacing up their shoes.
Very true.
So to bring all of this highly complex biology back down to earth for you, the listener, here is the ultimate takeaway from this deep dive. If you are a patient, particularly a breast cancer survivor, who is suffering from severe structural vaginal atrophy, and you found both local estrogen and PRP to be either contraindicated or entirely ineffective,
Right.
exosome therapy represents the most promising theoretical upgrade in the pipeline. By utilizing cell-free, hyperconcentrated signaling molecules derived from robust young donor sources, this therapy completely bypasses the limitations of your own aging cells.
And when formulated with an advanced delivery system like a slow-release hydrogel, these exosomes can act as molecular foremen. They successfully command dormant tissue to aggressively synthesize new collagen, sprout vital new blood vessels, and structurally reverse the thinning of the mucosa.
It is no longer science fiction. It is proven biology in the lab. But the journey from the laboratory bench to a standardized, FDA-approved treatment in your doctor's office is still actively underway.
It is, and, as we watch that journey unfold, it leaves us with an incredibly provocative question about the future trajectory of regenerative medicine.
Oh, what's that?
Well, right now, we are harvesting these biological flash drives from natural sources like umbilical cords and colostrum. But what happens in a decade when biotechnology allows us to synthetically write our own molecular code into these lipid vesicles?
Oh, wow.
Right. What happens when a doctor can program a custom exosome payload that commands the exact thickness, vascular density, and elasticity of the tissue we want to grow, perfectly tailored to the specific genetic blueprint of a single patient?
When the old blueprints fade, we won't just borrow new ones, we
Right.
will literally write the code from scratch. That is a wild thought to leave you with. Thanks for diving deep with us today.